This is John Gaffin, and I'm going to be speaking to you today about pediatric lung function testing and really honing in on spirometry. The key objectives to this talk are to know how to measure different aspects of the respiratory system, really understand the who, what, and hows and how-tos of spirometry, understanding how to interpret spirometry, the role of spirometry in the diagnosis and management of asthma, and how to identify abnormal spirometry that would require further evaluation. So there are a number of different tools within the pulmonary function testing laboratory that can assess different parts of the respiratory system. And so as a provider, you really want to be asking the question of what you want to measure, and then thinking about the tool for how do I measure it. And so if you're thinking about airflow obstruction or limitations, then spirometry is a great tool. You can do bronchoprovocation tests, which we'll talk about a little bit later. If you think that somebody may have an upper airway constriction, you could use inspiratory loops in spirometry. If you're thinking more of a restrictive problem, then you'd want lung volumes, and you can use body plethysmography or a helium dilution technique to measure lung volumes. You can look at respiratory muscle strength with MIPS and MEPS, inspiratory pressures and expiratory pressures. Or a diffusion of gas using a DLCO, or even more simply, just doing exercise testing to see if somebody becomes hypoxic as they increase their cardiac output. Other tests include control of breathing evaluation, and that is best done with a sleep study, otherwise known as polysomnography, or if there may be multiple organ systems involved that you're considering, then an integrated cardiopulmonary exercise testing, or a CPET, would be the way to really be able to differentiate what it might be a cardiac limitation versus a pulmonary limitation to someone's exercise tolerance. And then finally, really just looking very specifically at gas exchange abnormalities, for which just doing an arterial blood gas or a venous blood gas may give you all the information you need. So for the rest of this talk, I'm going to focus just on spirometry. And to start with, this diagram highlights the fundamental physiologic measurements that we're doing. And if you look at the figure, the tube that's leading from the person's mouth into this old-fashioned spirometer is about the same size as their trachea, and that's intentional because you don't want to add any airflow limitation by your measurement device. And then that tube leads to two cylinders that are stacked on top of each other, and ideally in a frictionless system. And so as the person breathes in, the cylinders close together because air is being removed from the system. As they breathe out, the cylinders separate from each other, and so the top cylinder rises. And you can see it's attached to a pulley system, and on the other end of that pulley system is a marker of sorts, and the spool is moving at a specific rate. And so as the person breathes in and out, the cylinders move up and down, the marker moves up and down with it, and because it's making a mark on a spool that's moving at a certain time, you can get the change in volume over the change in time, and that's basically the calculation for flow. We do have a couple of spirometers that use this mechanism to measure someone's spirometry. These are called rolling seal spirometers. There's a few of them in clinic, but for the most part, people use pneumatic spirometers, and those are ones that are laptop based, and usually it's a tiny little box that's connected to the mouthpiece of the spirometer, and what you're measuring there is you actually measure the flow at the mouthpiece, and then you can back calculate the volume. The key piece of doing spirometry is getting good quality data, and this really comes down to getting a child to perform the procedure in the appropriate way, and ultimately it comes down to having good PFT techs coaching them through the maneuver. So what you want is to have the child place a mouthpiece in their mouth. They're sitting up straight with their feet on the floor. The nose is occluded either with their fingers or with a nose clip, and they'll start with normal tidal breathing so that you can see the signal on the screen that you're measuring. And then at the end of an exhalation, as you're predicting the end of the exhalation because you've seen a few tidal breaths, you coach them to take a giant breath in, and and they inhale as much as they can to essentially total lung capacity, and then you scream at them to blast out and keep going, keep going, keep going, so you can get the forced portion of the flow volume curve, the maximum flow as they're blasting out, but then also getting them all the way down to the residual volume so that you're really measuring their total vital capacity. And after each one, you should examine the flow volume loop as well as the volume time loop to ensure that they plateaued their spirometry, and I'll show you some more about that. So in interpreting spirometry, it's nice to have a stepwise process. So the first is, as a provider who might be looking at the tests outside of the testing situation or the testing session, what you need to have to meet your American Thoracic Society criteria are 3 acceptable curves, and at least the top 2 of those acceptable curves being reproducible or repeatable. The criteria for acceptability include start of test criteria, which is called the back extrapolated volume, and that's essentially making sure that you didn't leak out air before you started recording, or before you started to really get your best blast out. The second is looking at curve configuration to make sure that it's free of artifact. And then the end of test criteria, which is that when you look at your volume time curve, that the patient blew out to the point where there was not more than a minimal amount of extra flow per time, and so the curve looks like it plateaus. Another way of looking at this, particularly in older kids and adults, is the total expiratory time. And for that, there are some criteria that if you're over 12, you should be able to exhale for greater than 6 seconds. Frequently, that's not the case, and so long as it plateaus, then it's a reasonably acceptable maneuver. And then repeatability, which also people frequently say reproducibility, is that your best forced vital capacity and your second best forced vital capacity have to be within 150 milliliters of each other, and the same thing for the FEV1. And they don't always have to come from the same curves. So if your best curve has a forced vital capacity of a certain number and your second best comes from the third time you blew out, then that's okay. And the FEV1 can come from the fourth time you had an effort, and that's also okay. And in the end, this data is compiled as your best efforts from all of these. And so this is the graphic of what you might see when you do your spirometry. On the left is a figure of a volume time curve, and you can see that it rises quickly and then it leads to a plateau as you get out in time. And then on the right is the flow volume curve, and the expiratory phase is above the horizontal line here, and you can see that again there's a rapid rise to peak flow and then the more smooth descending limb to where you get to residual volume. And then if you ask for it, and you have to ask specifically if you want to be able to interpret an inspiratory limb, then the inspiration comes below the line here. And here's some labels to show you. So the back extrapolated volume is really describing this point of how quickly that you have your rapid rise in flow. And if that were slower, or if it looked like it went too far back, it would indicate that the person kind of leaked out air before they got to their forced effort. And that can throw off your FEV1, which is a really important marker because some of that volume was already leaked out. The plateau I mentioned, and then the smooth descending limb. So those are the 3 parts of our acceptability criteria. And the measures that we get here are the forced vital capacity, and you can see that it's along the horizontal axis here, and that is the maximum volume exhaled from maximal inhalation. The forced expiratory volume in 1 second, or FEV1, is the volume that's exhaled within the first second. And so what's actually happening here, even though we have a little mark on this horizontal line that says FEV1, is that you take the time measurement from your volume time curve, that's marked here, and then it's just the area under the curve on the flow volume measurements here that is the forced expiratory volume in 1 second. And then the ratio is important. It's the FEV1 divided by FVC. and that gives a nice indication of of airflow obstruction. And so the actual data that you might see on a printout here after you've examined your curves is given in the actual amount, the predicted, and then the percent predicted for each of these parameters. And highlighting here that the FEV1 to FVC ratio, that actual is less than predicted, and in a kid, less than 80 is considered obstructive, even if the FEV1 is in the normal range. So some pitfalls in the performance of the test, and this will come to people who are reading pulmonary function tests, even if they're not watching the maneuvers take place, can be identified in the curves themselves. So looking at a flow volume curve, you can see that for this one, there was a little blip of an exhalation before the person actually gave their forced exhalation, and so that'll underestimate their FEV1, and that should be excluded. This is what coughing looks like. So there's an exhalation, but then sort of interspersed in here, there's complete glottic closure, which is part of your cough mechanism, and that gives this sawtooth appearance. Early termination is when someone does do a nice exhalation, but then it's very clear that they either close their glottis or they stop giving any effort, and it has this sort of ski jump or cliff appearance at the very end. And you can also see this in the volume time curve as well, because it won't plateau. And then a submaximal effort. This is a little bit trickier because in young kids you can have a more curved appearance to the flow volume curve, but typically you want to see a nice rapid rise to a peak in peak flow, and it wouldn't be as rounded as this or prolonged as this. And then in real life you'll get a mix. Here I'm showing you some real-life data on pulmonary function testing from a child. And what you end up seeing is a mix of all of the things that I mentioned before, or at least a few of them. Some nice rapid rise to peak flow in the descending limb of the flow volume curve. Looks pretty good for most of them. But here's one where clearly the person started out giving a good strong breath and then kind of let off the gas a little bit, and then was probably coached here to breathe out more forcefully, and then they picked it up again. But that would be a curve that you wouldn't want to use because it clearly has early termination or just an inappropriate flow volume curve. And you can see it both on the left panel, which is the flow volume, as well as in the volume time. Sometimes you can only see these things on one of those two graphical presentations, and so it really is important to look at both. So switching to the utility of spirometry, now that we've identified how we're going to find quality and reproducible tests, really what we're using spirometry is to answer a few questions. The first is this normal or is it abnormal? And then if it's abnormal, trying to get a sense of, does this look like an obstructive respiratory defect or is it a restrictive defect? And then if it's one of those two, particularly if it's obstructive, what's the severity of obstruction? And there's some guidelines for how we should rate severity. And then, is it reversible? So for children and adults with asthma, if there is some airflow obstruction, if you were to give them albuterol or other bronchodilator, you should see some airflow reversibility, which is part of the definition of asthma. The other thing that you get from spirometry is an ability to evaluate for alternative diagnoses. And you may notice that it is abnormal, but it doesn't fit either of these patterns, or it doesn't fit an obstructive pattern, or it doesn't reverse. And then that may spur you to think about other potential issues with someone's lungs. When we look at obstruction, we're thinking about a reduced FEV1 and a reduced FEV1 to FVC ratio. Restriction typically is a reduced FEV1 and a normal FEV1 to FVC ratio. So the flows are low, but they're symmetrically reduced. And this is best identified here as a suspicion and then proven with lung volumes as a follow-up test to really understand whether there's a restrictive lung disease component. In the diagnosis of asthma, obstruction is the hallmark. FEV1 is typically diminished, and that's in adults more than children. In children, the FEV1 to FVC ratio is low, and that is the most sensitive marker for airflow obstruction and can differentiate healthy from asthmatic populations. The other criteria is that it should be reversible with bronchodilators. Typically, characteristic guideline-based improvement with bronchodilator is an improvement in your FEV1 by 12% and 200 milliliters. This is mostly based on adult data. In pediatric data, there have been signals even as low as an 8% improvement showing a differentiation from an asthmatic versus a non-asthmatic population. But by and large, we really gauge these on a 12% improvement in 200 milliliters. Bronchoprovocation testing can be helpful when you still suspect asthma, but the spirometry appears normal to you. And there's two different ways that we can look at bronchoprovocation testing. So the first type is by direct stimuli, and these are things like methacholine and histamine. For these methods, the chemical is inhaled, it directly affects the smooth muscle around the bronchi and causes constriction. And so it is quite sensitive to detecting people who have asthma, in that they'll have a PC20, which is concentration of drug that decreases their FEV1 by 20%. That's within a certain standard that will ultimately say that they are more hyperreactive. The other category of tests are called indirect stimuli. These are tests where you have exposure to an agent that then leads to a downstream effect, so particularly cold air, exercise, or hyperventilation that causes changes in the osmolality of the airway surface liquid that then leads to histamine release and then leads to bronchospasm thereafter. These tests, the ones that are performed in our lab currently, are exercise-induced asthma testing as well as hyperventilation. And if you see a 10% decline in their lung function from before the test to after the test, then that is diagnostic of an abnormality and evidence of airflow obstruction or airway hyperresponsiveness. In regards to how we use this in the management of asthma, I'm just pointing out that in the 2007 NAEPP guidelines, which we still operate from, we're looking at classification of asthma severity in children. There is this portion of impairment that's measured by lung function. Intermittent asthmatics, which is basically the same as people without asthma, would be characterized as someone who had an FEV1 greater than 80% in a ratio, this FEV1 to FVC ratio, that's greater than 85%. And you can see as you get into higher severity ratings of asthma that the FEV1 will go down as well as the FEV1 to FVC ratio. And so if you have spirometry available, these should factor into your classification of asthma severity. And just to point out that when we look at asthma control, also within the same guidelines, those lung function parameters can also be incorporated. Here, it's looking at your percent predicted or the percent of your personal best spirometry if you've already had it done. And then lastly, just to review a few alternative diagnoses that may come up when you're reviewing spirometry, there are a couple of things that are presented in this figure. On the top left panel is normal. The expiratory limb looks good, and there's a full inspiratory limb as well. On the top right, this would be what an extrathoracic upper airway obstruction might look like, where the exhalation looks fine, but on the inhalation, there is a flattening of the inspiratory curve. The bottom left is what a variable intrathoracic airway obstruction might look like, such as tracheomalacia or certain soft tissue issues that might compress the trachea. And so you see that the inspiratory limb looks fine, but during the exhalation, there's a flattening, and they never quite reach a nice peak flow. And then the bottom right is fixed airway obstruction, fixed upper airway obstruction or central airway obstruction, such as a complete tracheal ring or stenosis. And this has the flattening both in the expiratory limb and in the inspiratory limb. So I'd like to review a few cases that will highlight some of these points that I've made in the slide set. So this is a 9-year-old with cough and wheeze, and if you look at the left panel, the flow volume loop here has a characteristic scooping component to it, which is consistent with an airflow obstruction. The arrow points to that. And if you look at the right panel with all the numbers, I've highlighted that the FEV1 is 65%. You can see the FVC is 86%, and the ratio is 66. And here we typically will look at the absolute ratio rather than looking at a percent predicted, although in newer guidelines there is suggestion that you can use a below the lower limit of normal as a definition of obstruction as well. And so just to highlight scooped curve configuration, a reduced FEV1 and the reduced FEV1 to FVC ratio definitely tells us that there's an obstructive ventilatory defect here. After receiving albuterol, you can see that the curve itself looks much better. There's a higher peak flow. The descending limb is further out, showing that there's been reversal of some of that obstruction, and a significant improvement in the numbers. So specifically, if you look at the FEV1, we have a greater than 12% improvement and also greater than 200 milliliter improvement from the pre to post albuterol spirometry. Incidentally, the FEV1 to FVC ratio also increases, although there's really no guideline-based definition for what is a significant improvement in that parameter. So that's somebody with asthma. The next case is a 10-year-old with chronic cough, and this is overlaying both the pre and the post bronchodilator spirometry. And you can see that there's still this area of scooping, so there's some obstruction there, but there's really no difference after they got albuterol. And so it is airflow obstruction, but it is not technically meeting diagnostic criteria for asthma. And this is a child who ultimately had bronchiectasis. And without doing the bronchodilator reversibility test, you may not have known this because he also presented with chronic cough, similar to how an asthmatic might. So in this slide, I'm showing you a 14-year-old who presented with shortness of breath. The quality of this test is certainly not perfect, but what I want to highlight here is the relative absence of a peak flow. If you look at the flow volume curve on the left, you don't have that nice triangular modeling that we see in the dashed line, which is our prediction. Instead, it sort of reaches a peak around 2 liters and then kind of flattens or peters out there. When we look at the numbers, you see that the FVC is 89%, which is normal range. The FEV1 is 62%, which is low. And the ratio is also low. And so this may have been misinterpreted as just sort of typical asthmatic airflow obstruction based on the numbers, but by looking at the curve, you get a better sense that there's something more central airway about this level of obstruction. And this is a child who ultimately ended up having a diagnosis of tracheal stenosis. The next case is an 11-year-old boy with a weak cough. And here you can see that the quality of the test is reasonably good. When you look at the volume time, he does plateau. The flow volume curve looks pretty normal, except it looks like it's just a shrunken version of what our predicted curve is. And this is pretty typical of what a restrictive lung disease might look like on spirometry. In here, the vital capacity is 60% and the FEV1 63%. And most notably, if you look at the ratio, it's above 85%, which is a normal ratio. And so this is a child who has Duchenne's muscular dystrophy. Lastly, I'll show you an interesting curve of a 10-year-old who presented with dyspnea and cough. And this is a patient who was in the ICU at the time that I brought the spirometer up to do their expiratory and inspiratory flow volume loops. You can see from the volume time that they actually did a reasonable job of getting full exhalation, but here both the expiratory limb and the inspiratory limb have a flattened or capped appearance. It's never going to be as perfect as the drawings I showed you earlier, but you can get a really good sense that there is expiratory flow limitation and inspiratory flow limitation. And again, this is a child who had severe croup, and so had the tracheobronchitis and narrowing of the central airways. So to summarize the presentation today, there's a variety of pulmonary function tests to evaluate airflow, lung capacity, gas exchange, and control of breathing in children. And identifying which of these tests will best answer your clinical question is really important. Spirometry is an extremely useful tool for determining airways disease. Bronchoprovocation testing is useful as an adjunct to confirm airway hyperactivity, especially in someone who has normal lung function testing. And that irreversible obstruction and restrictive appearing spirometry should be further evaluated, either with different types of lung function testing or other modalities. And that is the end. Thank you for your attention.